me. I'm going to talk shortly on anatomy and biomechanics of lateral extra-articular tenodesis as well as the ALL ligament. And what has been the reason for this invention is a residual rotational instability, in which is published by many researchers, where they found out the lateral pivot shift as compared to the ACL constructed, reconstructed with ALL, without ALL, the lateral pivot shift is always an residual instability in ACL reconstruction. And this led to invention of something which is not been seen very clinically in your clinical practice, but it could be an accompanied. Way back in 1980s when Houston and others, they projected this anterolateral instability. It was considered as a flawed concept because the tibia could subluxate in extension and femur could drop back, and they considered this as a simple pivot shift because of ACL. But the ACL instability is not a simple instability, because when you have a torn ACL, there is usually 15-degree shift in your knee joint, and this shift will mimic with at least 6.7 mm shift of the lateral femoral condyle on your medial or tibial femoral condyle. And this translation will be picked up as a pivot shift instability around the knee joint. And to make it more complicated, then there is a discovery of new ligament which was published in Times of India, and it was published in many articles, and they said that this Times article said that this new ligament is ALL, that is anterolateral ligament, and this is the most important problem of your knee joint which leads to the pivot shift instability. Although there are other researchers, they found out the anterolateral rotary instability could be because of meniscal root tear, ramp and other associated injury, or it could be because of malpositioned tunnels, especially in the revision scenario. The impact of anterocruciate deficiency knee is very important, because whenever you have a ACL deficiency knee, usually the lateral kinematics of knee joint will get altered as compared to the PCL deficient knee, which usually lands in the medial kinematic damage, leading to varus instability or varus malalignment. So one has to be very, very sure when you're dealing with ACL, remember that there could be a rotation of the tibia which will lead to a lateral instability of the knee joint. Stephen Class has described this as an anterolateral ligament, as the ligament which starts midway between the Gerdy's tubercle and the fibula head, as you can see on your this picture, and then it goes above the lateral collateral ligament, proximal and distal to the lateral collateral attachment. So it's a little bit of superficial ligament which goes superficial to the lateral collateral ligament, as described by Stephen Class, and this ligament is the reason, as per his paper, that lead to a pivot shift instability. Whether it's a new research? No, not at all, because way back in 1879, Segond has first described the lateral capsular avulsion, which was treated, and they found very good stability in those patients. And eventually there are many papers which are presented there, capsulo-osseous ligament or posterior oblique ligament or lateral oblique ligament, mid-third lateral capsular ligament. These are a different nomenclature which was given to the ALL. So what's in the name? There is nothing in the name. The only thing is the structure which is causing this instability needs to be reconstructed or recreated so that add the stability. Then came the concept of horseshoe figure formation of the capsular structure around a knee joint. This is proposed by Moses Cohen from Brazil, and they found out that unless you complete this circle of ACL and the ALL or the lateral capsule, you will not get a complete stability. So depending on that, they described the U-shape base concept of the lateral capsule, and that lateral capsule need to be corrected before you plan a reconstruction. So whether it's a fact or reality, one has to find out. We have done a lot of internet research, and we found out that at certain papers there is a conflict of interest, and there are different groups which propose each other's theory as a wrong theory. The first description of the lateral laxity and the anterolateral complex injury came from Andrea Ferretti. Is a classical example where he described type 1, type 2, and type 3, depending on type 4 lesion is a Segond type of avulsion. Type 1 is a simple microcapsular avulsions. So microcapsular lesion, if you repair, you get a better result, and type 2 and type 3 needs to be reconstructed so that you can get a better outcome. So that's a basic description as described by the Dr. Andrea Ferretti, which is microscopic lesion, and these have certain positive correlation with lesions of lateral compartment and pivot shift, and that led to a discovery of your ALL reconstruction. So anatomically, when Stephen Klaas described this as a ligament, they found the ALC consensus study group, they found a new part of lateral collateral ligament, that is the superficial IT band. The new structures added were Kaplan deep Kaplan fiber system and retrograde condylar attachment continuous osseous layer. These are the new structures which are added on postlateral complex along with the ALL and the capsule. So now the previously described postlateral complex as PLC, now there is an anterolateral complex injury and that need to be tackled as a deep fibers and Kaplan fiber system so that you can get a stability in your knee joint. And this could be superficial or deep, described by different researcher. If you see the work by Andrew Emis and the group, they say it's a deep structure, whereas the Soneri Coated says it's a superficial structure. So there is a study by Alan Goodgood, again from the ALC group, which says that the ALL ligament goes superficial to the lateral collateral ligament and it attaches in a midway between the fibula head and the Agardis tubercle. So the tibial attachment is very common here, is not debatable. The only part which is debatable is the femoral attachment. Certain researchers say it's proximal to the lateral collateral or lateral epicondyle where the lateral collateral originates. So, Soneri coated are typically found at posterior and proximal to lateral epicondyle is attachment to the femoral side, and this origin directly adheres to the bone, has a mean diameter of around 11.85 mm. And this is very important because whenever you are reconstructing ALL, you have to reconstruct this ligament in similar fashion. Remember, it's not very deep, it's very superficial and close to the tibial joint, and from there it goes to the attachment to the lateral collateral ligament, anterior and proximal. So ALL is a fibers which continue to run distally and they form a fan shape like insertion from that area, and it adds to the stability. So biomechanically, if you see, the mean load to failure is around 180 Newton, and this has a stiffness of 31 Newton, and the functions as it is a most important restraint to your pivot shift activity. And this anterolateral complex group has found out that it is not the only ALL, even the ITB and Kaplan fibers and even the lateral meniscus will add to the pivot shift instability if not treated well. So there is a conflict that whether ALL is isolated only structures which add to the pivot shift or the other additional structures. So anterolateral complex group, they found out that time zero biomechanical studies have showed that ACL reconstruction can prevent the rotary instability, provided you have to constrain the lateral compartment either in the form of ALR or LET. So do all ACL requires lateral augmentation is a debatable question, and there are many studies which have shown that only revision scenario, high grade pivot and generalized ligament laxity, you should consider the ALL type of reconstruction. Soneri Kotet has produced this work where he has combined this with the ALL reconstruction, where he says multi-fang or triangular fan-shaped strike structure reconstruction of ALL is very important when to add to the stability. And he has given an algorithm where he says the pivot shift grade 2 and 3, you always add ALL as compared to the normal ACL. What about lateral extraarticular tenodesis? This is a work which started in 1967, and from Lemaire to McIntosh there are various techniques which have been described. Superficial or deep Lemaire is a different, two different techniques. You can use modified McIntosh type of technique where you can have elongated insertion of your proximal fibers, Kaplan fibers, depicting the Kaplan fiber, or you can have a modified Ellison which mimics your more of a ALL reconstruction. So there are different procedures, different techniques which have been described. This is the modified Ellison. You can take a distal, a proximal base flap, you can remove the attachment from the distal side and go beneath the lateral collateral ligament so that you can get a better outcome. So I'll go quickly from here so that we can finish in time, and this is how you can go beneath the, you have to create the whip stitch and then just go beneath the lateral collateral ligament, superficial, and then you can fix it on the tibial side. So this is more like a ALL reconstruction as compared to the lateral extraarticular tenodesis. But this is not a true ALL reconstruction. Then there is a modified Lemaire technique, which is an extraarticular technique. Again, you have to take the distal base flap. Here you have to exercise from the proximal area, IT band, go deep and then fix it on the lateral epicondyle, proximal and anterior to the lateral epicondyle so as to add the stability. So these are the two commonly used technique which we use for ALL. Anterolateral ligament augmentation has prevented the pivot shift deformity and pivot shift result, and this can lead to the very good stability as by Santi group. And the ALL has been very systematically reviewed by many researchers, where it prevented failure of ACL and graft failure in certain studies. So semitendinosus was commonly used graft in ALL reconstruction so as to reduce the re-rupture rate, and there are many ways to do it. The commonest way is the effect of ACL you can combine with either a ALL or a modified lamella technique, and both have shown a very, very positive result. In short, the anterolateral ligament needs to be reconstructed so as to improve the biology and the anatomy of your ACL, because the U shape and the fan shape structure of ALL will add the stability of knee joint. So lateral extraarticular tenodesis basic function is it shifts your center of rotation on the lateral side with more on the more tightening. So take home, remember that whenever you have a pivot shift which is grade 3, always add the ALL or the lateral extraarticular tenodesis. Generalized ligamental laxity needs to be taken care of with this. High demand athlete, whenever you want patient to go back immediately in contact sports, and any revision scenario, please add lateral extraarticular tenodesis. Thank you.